Hi, I'm Myra Butler, a recent grad from UBC Medicine and currently completing my MHSC in clinical epidemiology. In this module, I will reintroduce you to the field of epidemiology and the basics of epidemiologic methods. You will also learn how to distinguish a count from a rate, incidence, and prevalence. Breaking the term epidemiology into its parts helps with understanding the field. Demos means the common people. Epi, upon, and ology, the study of, or the study of the common people. This emphasizes the fact that epidemiology rarely deals with the individual patient, but rather with the health of populations. Here's the full definition for your reference, should you need it. But the short version is that there are two types of epidemiology, descriptive and analytic. Descriptive epidemiology focuses on describing person, place, and time, whereas analytic epidemiology uses different study designs to test hypotheses. For example, one might use a cohort study to test the hypothesis that a rare exposure to some agent causes cancer. The purposes of epidemiology include setting out a structured and repeatable way of conducting research, examining data on the basis of person, place, time, and cause, defining the population at risk to obtain rates, measures of risk, as well as information for determining resource allocation. With specifically defined measures, it is also possible to compare populations and treatments. Finally, you can explore associations to see if they represent a causal relationship and evaluate intervention effectiveness. When faced with problems like what causes lung cancer, or is this recently noticed symptom of a new medication a true side effect, or the result of a placebo effect, turn to the epidemiologic approach to get started. First, gather the raw data about the problem, being as specific as possible. You may want to consider setting out a clear case definition at this point. Next, organize your data based on characteristics of person, such as gender, age, or ethnicity, place or setting of the event, and time. If possible, recording the cause or speculated cause may also be helpful. The next step is to determine the population at risk. For the example about the possible new side effect, gather together all the information about the new side effect in the drug and placebo groups. Initially, you want to organize based on whether they received drug or not. The population at risk of the side effect is the population that received active drug. Calculate your proportion as the number with the side effect over the number who received active drug. Next, you compare populations and subpopulations. In this case, you compare the proportion of those with the new side effect in the drug group as compared to the placebo group. Using statistics, you can look for an association, or in this case, a significant difference in the proportions between the drug and placebo groups. Remember that if your data is scant, you may not have power to detect a real difference, even when it is there. You may have noticed that we have moved seamlessly into hypothesis testing in the example, testing whether the new drug actually causes the new side effect. Other hypotheses to test might be things like, is there a subpopulation that is more likely to get this side effect? Or, are there any circumstances that seem to mitigate or reduce the likeliness of this side effect? These types of hypotheses lead you into the next step of the epidemiologic approach, which is the development of interventions and/or therapies for the condition. Remember to build the measurement of effectiveness of the new therapies or interventions right into the trial and save yourself the headaches in the future. Let's be clear about some epidemiology definitions. An outcome is the disease or parameter of interest in a trial. For example, when trying to find out what causes lung cancer, you might choose new lung cancer diagnoses as the outcome. Exposures are more difficult to pin down. An exposure can be essentially anything from contact with an infectious agent, to age, to having a particular surgery, to living in a certain town at a certain time. They can cause disease or physiologic effects, they can protect from disease, they can confound the relationship with the true cause, The exposure may modify the effect of another exposure. Another important distinction to remember is that the exposures may not only be one-time events like surgery, but may also be cumulative. For example, a single exposure to asbestos is not likely to cause mesothelioma. However, repeated exposure over many years dramatically increases the risk. Thus, in this example, one may more readily define exposure as having worked in a high-risk occupation. Take a moment to work out the outcome and exposure variables for the following examples. Example 1, the exposure is surgical lung biopsy, and the outcome is interstitial lung disease. Now try example 2. The exposure is a posterior chamber intraocular lens, while the outcome is the degree of myopia. Now that we know how to spot outcomes and exposures, we need to consider ways of measuring both. As you can see from this simplified list, there are many ways of measuring, spanning from simple counts to prevalence and incidence. A count is a pure number of events or patients. Although this is often the easiest number to generate, there is no overt population at risk, or as epidemiologists like to say, there's no denominator. Nevertheless, there can be an implied population at risk. For example, I have been in practice 25 years and have only seen one case of pheochromocytoma. The implied denominator is the number of patients through the clinic door in those 25 years. On the whole, however, counts are not looked upon favorably since they are essentially floating numbers without context. The next step up from a count is a proportion. A proportion can be as simple as a count with a denominator. For example, 5 people with mononucleosis is a count. 5 students at a college of 500 gives a proportion of 1% of the students, while 5 students of a 20-person dorm gives a more interesting proportion of 25%. As you can see from the example, the essential question is, how do you choose a denominator? One answer to that question is to use a time frame. In other words, calculate a rate, which is a count over a period of time. An example of a rate could be the number of patients through the door of an emergency room in an hour. This option, however, still doesn't give a sense of the population from which these people are drawn. In order to have standardized ways of choosing a denominator, special types of proportions were defined. Prevalence is the number of people with a specific outcome over the average population. For example, the prevalence of childhood leukemia in BC for 2012 is the number of children having leukemia at any point in 2012 divided by the average population of BC for 2012. Getting even more specific, there are different types of prevalence. Of particular interest are both point and period prevalence. Point prevalence is the number of people with a certain condition or outcome at a specific point in time divided by the population at that same point. It's like a snapshot prevalence measure. Period prevalence, on the other hand, measures prevalence over a specified period of time. This is like a movie prevalence. One way that the denominator can be approximated is by using the population at the midpoint of the time period. This assumes that the turnover in the population will be approximately equal between the first and second halves of the period. Although prevalence is a useful measure, especially when trying to allocate resources, it is not a measure of risk. In order to assess risk, you must measure the population at risk. For example, if 4 out of 10 people have sunburns, the risk of getting a sunburn is not 40%. It may be that only 8 of those people were actually in the sun. In order to assess the risk, you must consider a proportion of those at risk of the outcome. Since 2 of those people were not in the sun, they were not at risk of sunburn. So the actual risk of sunburn in this case was not 40%, as you would expect from the prevalence measure, but actually 50%. Incidence. This measure takes into account those at risk of the disease. Incidence is the number of new cases of the outcome divided by the population at risk within a specific period of time. Let's compare prevalence and incidence to better understand these terms and their usefulness. The numerator for prevalence is all people with a certain outcome, while the numerator for incidence is new cases of a certain outcome. The denominator for prevalence is the average population, while the denominator for the incidence is the population at risk. Remember, for both prevalence and incidence, you must be clear about the time period of the measurement for both the numerator and denominator of each. Consider now the usefulness of these special proportions. Prevalence is a good measure of disease burden, or how much of a certain outcome is present in a population, which helps for determining resource allocation. Incidence, on the other hand, is a good measure of disease risk. As such, incidence is often the measure of choice for determining causal relationships and disease risk factors. Just as prevalence has specific types, so does incidence. For incidence, however, the most common distinction is made between cumulative incidence, which is used for a stable study population, and incidence density, which is used for unstable populations. Cumulative incidence is the number of new cases during a period divided by the population at risk at the beginning of the period. Incidence density, on the other hand, is the number of new cases during a period divided by the total person time at risk during follow-up. For example, at a teen clinic for STI measurement, new STIs are measured with the denominator of person months of follow-up. If there are 50 teens followed for 6 months and 10 teens followed for 1 month, the total person months would be 310 person months. Remember that a person is only considered to be at risk while they are being observed. Prevalence and incidence are actually related by duration. As the duration increases, so does the prevalence. This relationship can be better understood visually in this example. In the diagram, each arrow represents a person at risk. Blue arrows represent those who are at risk but do not develop disease, while yellow arrows represent those who do develop disease. On the left, the duration of the illness is short, and 2 of those with disease are not caught during the time of measurement. On the right, however, all 5 people with disease are detected in the same measurement period because the duration is longer. In other words, the prevalence of the disease in the left-hand diagram is less due to the shorter duration of the illness, even though the incidence remains constant between the sides of the diagram. I find it helpful to visually represent some of these concepts. In this example, the red balls coming into the yellow bowl represent people with the outcome appearing in the population. The 2 main ways this happens is through new cases of disease or through immigration into a population. Divided by the population at risk, this gives a measure of incidence. Likewise, once there are cases, they can leave the population through cure of the illness, death, or emigration out of the population. If the incoming cases and outgoing cases reach equilibrium, you can approximate the prevalence. Here is a summary of the material we have covered in this module for future reference. It is also available as a PDF for your convenience. Now let's see how well you understood the material. What are the outcome and exposure in this study? The outcome are 4 types of intraocular pressure measurement, while the exposure is corneal thickness in keratoconus corneas. How about this scenario? The outcome is the adenoma detection rate, ADR, and the exposure is diverticulosis. Remember that with real studies, you often have a lot of information to sift through. Wading through all the extra information and defining your outcome and exposure explicitly is a first and crucial step in understanding the study and evaluating its validity. What type of measure is 46.8 deaths per 1,000? This is a proportion. For those interested, it is another special type of proportion called the cause-specific mortality rate. What about the next example? This is a count. What are the 2 types of measures in this first example? (526) is a count, and 3.3 per 1,000 child months is a cumulative incidence. What about this last example? Despite the word prevalence in the sentence, this is actually a count. Prevalence is implied since it can be calculated by dividing this count by the average world population. I hope this presentation has helped you to understand a little about the field of epidemiology and an epidemiologic approach to research. Be sure you understand the differences between the measures, especially between prevalence and incidence. The material for this presentation was drawn from the 4th edition of Epidemiology by Gordis and from Dr. Richardson's Introduction to Epidemiology class at the University of British Columbia's School of Population and Public Health. Thank you very much for your attention.